Thank you all for joining us today. Our program will begin in 1 minute. Good afternoon. My name is Amanda Scott, and I am the Senior Manager of Product and Membership Design at the National Quality Forum. Welcome to this latest program on how NQF members are responding to the challenges around COVID-19. We are glad that you could join us, and we hope it will be informative. This program is made possible by you, the members of the National Quality Forum. Members are the driving force behind NQF's mission to advance measurable health improvements. Together, we do the work that enhances healthcare value, makes patient care safer, and results in better outcomes. Members continually demonstrate their shared commitment to the NQF mission through engagement and service, and our presenters today are no exception. The National Association of Behavioral Healthcare has assembled a diverse panel of presenters for us today. Kirsten Beronio is a senior policy advisor with management experience. Her career has included working in various positions in the U.S. Senate, federal government agencies, and outside government and advocacy. She is also skilled in healthcare policy analysis, legislation development and strategy, Medicaid policy, and mental health and substance abuse policy. Kirsten is a strong healthcare services professional with a JD from Georgetown University Law Center. As president and CEO for Rutgers Health University Behavioral Health Care, Dr. Frank Ganassi is responsible for a statewide system of academically based mental health and addiction services across New Jersey, managing an annual operating budget of $320 million and 2,200 staff and faculty. UBHC, one of the largest providers of behavioral and addictions healthcare in the country, offers a wide range of clinical services across all diagnoses and across the lifespan, including inpatient units, partial hospitalization programs, intensive outpatient programming, case management, traditional outpatient treatment, correctional health care, a certified community behavioral health center, peer-operated helplines for service members, veterans, mothers of children with special needs, law enforcement officers, and child protection workers, a statewide suicide prevention hotline, and a clinical research and training institute, as well as an array of specialty and peer support services. Dr. Ganassi also maintains a dual role, serving as a senior vice president of behavioral health and addiction service line at RWJ Barnabas Health. His leadership has further positioned the behavioral health and addiction service line as a premier comprehensive behavioral health provider, serving as the preferred destination for patients, families, and clinicians who seek high quality, fully integrated and interdisciplinary behavioral health care throughout New Jersey. Additionally, Dr. Janasi is a professor at Rutgers Graduate School of Applied and Professional Psychology and adjunct professor of psychiatry at Rutgers Robert Wood Johnson Medical School, an adjunct associate professor of psychiatry at the University of Pittsburgh School of Medicine, and a core faculty member at Rutgers Global Health Institute. Dr. Janasi earned a BA from the Indiana University of Pennsylvania, an MA from Duquesne University, and a PhD from the University of Akron. His research interests include the implementation and evaluation of evidence-based treatments for mood disorders, quality of care and performance measurement metrics, and models for data feedback in changing practices and behavioral health. Ann Kelly joined Acadia Healthcare in 2012 and has more than 28 years in administrative leadership and direct patient care. Prior to joining Acadia Healthcare, she held various corporate and hospital-based positions, including Chief Safety Officer, Chief Nursing Officer, and Vice President of Compliance. With a nursing and clinical background, Dr. Kelly serves as the Chief Quality and Compliance Officer in overseeing Acadia Compliance and Quality Program with a focus on patient safety systems, staff training and education, regulatory compliance, and accreditation. She is a nationally known speaker on the use of high reliability principles in psychiatric hospitals and serves on the NABH Quality Council and the Joint Commission Health Systems Corporate Liaison Committee. Joe Pritchard is nationally recognized as a leader in the field of substance abuse treatment with more than 40 years of experience. In his role as CEO, he uses his extensive knowledge in operations development and strategic planning to provide patients the opportunity to restore their lives. Joe has built a team of renowned substance use disorder professionals who are committed to providing comprehensive patient treatment and care. Before we get started, I just want to go over a few logistics. We hope you'll take an active role in the question and answer portion of this program. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We have muted all lines to ensure that unexpected noises do not interfere with the program. They will be unmuted during the question and answer period, and you can also use the Q&A box at the bottom of your screen to ask questions for the end of the program. With that said, I'd like to turn it over to Kirsten Beronio to get us started.
Thanks, Amanda. Next slide, please. And thank you to everyone for joining us this afternoon. I'm Kirsten Beronio, Director of Policy and Regulatory Affairs for the National Association for Behavioral Healthcare. NABH represents mental health and addiction treatment providers that cover the full continuum of care, from inpatient to residential treatment to partial hospitalization and intensive outpatient programs, as well as medication-assisted treatment centers, including opioid treatment programs and other facility-based outpatient programs for children, adolescents, adults, and older adults in almost every state. As you all probably have been reading in the news, the COVID-19 pandemic is really having a singularly negative impact on the behavioral health of the U.S. population overall. I'm honored to be joined today by several NABH members who are really on the front lines for addressing this increasing need for behavioral health care in our nation. They're going to talk about what they're experiencing as behavioral health care providers, how the challenges they're facing, trying to address those needs during a pandemic, through everything from new protocols and policies to address infection control, to the greatly expanded use of telehealth and the need for flexibility around the regulations that surround addiction treatment. Really very critical as we're seeing that the COVID-19 pandemic is significantly exacerbating the opioid crisis. Sorry, next slide, please. And that's just a summary of us. So next slide. And just gave the overview. First, I'm going to give a little bit of a context for you know, the rest of the discussion. So next slide. So as we know, there are large-scale disasters like the COVID-19 pandemic are known to have widespread and long-lasting detrimental impacts on mental health and substance use. We're experiencing the beginning of those effects. You know, indications are seen in things like the recent CDC report comparing the second quarter of 2020 to the same time last year, where adults over 18 were found to be experiencing anxiety disorder symptoms that are 3 times higher than this time last year. The prevalence of depression is about 4 times higher. Twice as many people reported serious consideration of suicide in the prior 30 days. It's particularly prevalent among 18 to 24-year-olds, where the rate was over 25%. In the survey data, and then the data also showed elevated levels of substance use. And we've also been hearing and seeing in the data that drug overdoses are on track to reach an all-time high this year, with over 40 states reporting increased opioid-related deaths this fall. Moreover, recent research has found that people with substance use disorders have a heightened risk for COVID-19, and as well, people who contract COVID-19 are at risk of developing mental health conditions. In addition, there's an increased risk of contracting COVID-19 among those with pre-existing mental health conditions. So these conditions are very much intertwined, and the need to address behavioral health care is very, very urgent at this time. And what we've seen from past pandemics and natural disasters is that the detrimental impacts of these widespread occurrences really continue for years to come, and that often the distress and suicidality doesn't peak until years after the disaster. So we need to really be preparing for that. The members of NABH, I hear all the time about the concern they have for their staff. We're hearing reports in the news now increasingly about the strain on healthcare providers. We know from research even before this that particularly emergency room practitioners and female physicians were already at heightened risk for suicide. And we've seen that happen in China, where COVID-19 hit first, where there's been studies showing heightened symptoms of anxiety, depression, psychological distress among frontline workers. There was also research showing the heightened levels of distress, anxiety, depression among healthcare professionals following the 2003 SARS outbreak. I know Frank in particular is going to talk about some of the things they're doing at Rutgers to address this issue. And all of this is obviously creating an increased demand for mental health and addiction treatment. There's been, reports in the news about exponential increases in calls to crisis lines, and we are also hearing that from our members consistently, increasingly, that the larger behavioral health provider systems in particular are seeing big upticks in demand. At the same time, our members are really struggling with significant unexpected additional costs that are not generally reimbursed through insurance or healthcare coverage programs, like the technology that needs to be purchased to really take advantage of the expanded coverage of telehealth, the greatly increased need for personal protective equipment that behavioral healthcare providers did not really use as much prior to this, as well as the need for increased screening supplies and reduced capacity at the same time as we're trying to, they're trying to address, and implement infection control policies. I know Anne is going to talk about that issue some more. And then finally, we'll hear from Joe, who is going to talk about some of the special challenges that addiction treatment providers are facing. I'm going to highlight some of our advocacy priorities at the end, and then we'll open it up for questions. So with that, I will turn it over to Frank. Next slide, please.
Kirsten, thank you very much. And Amanda, thank you as well. And Joe, and it's great to see you both. Next slide, please. So you may have seen this slide before. This was based on some work that was done about 10 years ago. And it talks about the typical curve that is often seen in emotional impact post-critical event. And this sort of pre-disaster and then impact. And I think in some ways it echoes what's been going on here. For us, we began hearing about this in late December and early January, but there was a punctuated event when it made its appearance on the West Coast. And then there's this kind of period of what's often called the honeymoon period. Most of you probably in the neighborhoods you were in saw hero signs on windows and newspapers, and there's this surge of adrenaline-fueled care, and healthcare workers and population alike sort of feel like they're rising to the cause. The difficulty with this is that almost in all cases where this has been studied, there is this period afterwards where, whether it's cleanup from a natural disaster or whether it's the ongoing stress that's going with this, there is this then period of disillusionment, which then people slowly begin to reconstruct the life. Now, this is an imperfect model for what's happening with us, only because there are rolling issues happening here. It's not a punctuated event, which then has gone away. So I think we're going to see multiple cycles of something like this. And many people are talking about COVID fatigue at this point, and a lot of people really are feeling burned out. Next slide, please. So, you know, we look at these overlapping circles of response. There's a distress reaction. People notice changes in sleep, irritability, distraction. We see isolation and decreased sense of safety. There are health risk behaviors that we're all seeing, both in our populations that we treat and also the people that are our coworkers, where people habits like smoking and alcohol and over-dedication, where people are working 25 hours a day, and changes in travel because you can't do it, and a lot of separation and anxiety, which I think is going to be heightened now during the beginning of a traditional holiday season, where all of those things are going to be different. And in between those distress reactions and those health behaviors, then there is the overlapping diagram of true diagnosable psychiatric disorders like depression, PTSD, anxiety, and complicated grief. And we're watching the intersection of these three circles. On the other hand, we're a species that's been around about 100,000 years. And one of the things that we've learned about this species is that whether it's ice ages or widespread pestilence or global wars or genocide or all of the other horrible things that we've had to endure, including predators in the night, human beings have an internal sense of resiliency, and you're going to see that many people in the face of this are going to tap into that resiliency. What's impaired that a little bit now is that they're blocked from one of the things that helps with resiliency, and that's social contact. Next slide, please. Psychological first aids, next slide. The key on this really is coping on a cluster of things that we can do to help ourselves stay balanced. That's taking breaks from the 24-hour news cycle, making times to unwind from work. Many people are getting back into board games or gardening, if the system allows, allowing you time to do offline activities. Setting clear goals and priorities for yourself. People are working from home and they may have become less regular about their sleep and wake time. Exercise is critical during this time. Contact with others, whether it's virtual or not, or socially distanced, is critical. And the idea of focusing not so much on the endless news cycle of opinions, but maybe focusing a little more on what facts are out there. Next slide, please. The 5 major principles of psychological first aid really are safety, calmness, self-efficacy, connectedness, and hope and optimism. And I think these are things that we can evoke in ourselves, but we can also assist in invoking in others, including our children, our families, and our employees. Next slide, please. And then addressing the health needs of the greater community, please. Next slide. We're seeing, as Kirsten had pointed out, we're seeing exacerbations of anxiety, depression, substance use, loneliness, especially among the elderly, or even among millennials who are living on their own. And there is a concern that much of the domestic violence and child abuse issues that have been uncovered, often in workplaces or in schools, may now be going on invisibly because of the remote way in which we're now working and living as Americans. Next slide, please. Some of the solutions that you're going to hear about include, as Kirsten pointed out, a move toward digital technologies, social media, non-traditional groups for psychological first aid, which can include peer support specialists. It can also include local community supports in the way of help and aid that often many communities are now pulling together around. And this concept of social distancing and safe places, which is playing out across America. Like many of the people that you're going to hear about, the conditions you're going to hear about from Ann and Joe, most of us went from largely 90–95% in-person treatment to, at least in ambulatory care, to almost the absolute inverse. 95% of the care was being done virtually. And that happened not in years, it happened in weeks. Next slide, please. So some of the things that seem to worsen the impact of these situations, and this comes from that research on that chart that I showed you at the very beginning, is that the longer the quarantine duration lasts, the more severe and sustained the impact tends to be. And this has gone on now for 8 or 9 months, and there's likely not going to be a clear resolution for at least another 8 to 12 months. Inadequate supplies makes it worse, and inadequate information. And that's going to severely impact some of the most vulnerable people in our populations and those who are already affected by the social determinants of health: unstable housing, unstable food supplies, lack of access to the technology that keeps us connected. And finally, all of us have, on one level or another, experienced both the fear, frustration, and boredom that comes along with this. Many, many people are being financially impacted, and the stigma around behavioral and addiction health has also prevented some people from seeking help. Next slide, please. So again, giving as much information as possible, trying to make sure that supplies are adequate, and instilling in others the idea that doing for others, altruism in a time like this, calling neighbors who may be living alone, calling elderly people in your neighborhood or building who may not have anybody to reach out to them, that altruism itself is a two-way street. As much as it benefits the people who receive our outreach, it also benefits the giver. Next slide, please. What are healthcare professionals being asked to do from patients and coworkers? People want to be heard, they want to be protected, they want to be prepared, they want to be supported, and they want to be cared for. And I'm being very careful in messaging. I'm trying to avoid telling people we're going to keep you safe. I'm trying to use the phrase, we're going to do everything we can to reduce the risk, which I think is a truer statement. And I think very often setting up an expectation that complete safety may not be possible, it just feels to me more honest to say we're going to do everything we can to try to reduce the risk. Next slide, please. We talked about the move to telehealth. Most of you know about the platforms. There are many out there now that are HIPAA compliant. Next slide, please. We have about 15,000 prisoners who are serviced by about 8,000 or 9,000 officers, corrections officers, across 12 institutions in New Jersey. We provide the physical, behavioral, and dental health care for all of them. And since May, we've taken on a whole new profession. We are testing all 27,000 of those officers, inmates, and our 900 medical staff once a week, which is an entire new profession that we've got started in. Next slide, please. We have an extensive school-based programming, and that's all moved from real to virtual. We're in over 120 schools across 25 school districts, and most of that work had been done in person, and that's had to all be flipped to virtual because many of these kids continue to need even more behavioral health care. Next slide, please. Obviously, their workforce resiliency, we're standing up additional call lines. We have a dedicated Rutgers for You line, which is available to all 35,000 Rutgers employees and all 35,000 RWJ Barnabas employees. And that call line is open 7/24/365. Next line, please. And then we've set up interactive grids And I know everybody says this at least once in a presentation, so I'll say this. I know you can't read this, but these grids can be sent out electronically. Next slide. And what they are is they outline every single resource across RWJ Barnabas and across Rutgers, which assist people in all different levels of support. And each one of these are color coded. And when you tap your cursor on the link, it takes you to a full description of those resources. And we've distributed these things wide and clear across that. Next slide, please. And with that, I will say thank you, Kirsten and Amanda. And I get the pleasure of introducing my friend and colleague, Ann Kelly. Ann, it's all yours.
Oh, thank you, Frank. And hello, everyone. And thank you again for this wonderful opportunity to share our experiences and what we have learned already going through this remarkable pandemic. Next slide, please. You know, I've always known about our collective commitment to the importance of behavioral health services. You know, we've been fighting epidemics of suicide and drug abuse. Now we fight it against the backdrop of a pandemic. And I think for everyone right off the bat from behavioral health, I've been in behavioral health for 24 years, longer than that as a nurse, would have never thought in any of our settings, we would have isolation units, we would have staff wearing PPE constantly, or social distancing, especially for us in behavioral health. It's a very social place. It's a therapeutic place. So when the pandemic first started, even before the first patient was identified in the United States, we started thinking about like, what could this possibly mean for us? And how are we gonna still maintain this therapeutic environment while keeping everyone safe as best we can? You know, a lot of great endeavors and hard challenges, they're never done by themselves. And so fortunate for that for the work that I do it together with others. And I'm really, really so grateful for having an incredible team and facility leaders and staff that we all join together. And you know, the good thing about this is it's really brought us together in an enhanced way. And then having organizations like this and NABH to help us. So when it started and the pandemic was declared in March, it was really a first things first. And so, you know, behavioral health, we always have had infection prevention and control. To the extent it is now, no, this has been a game changer for us. So the things that we do from a plans and protocols and policies, all of that was enhanced. And from the very beginning, we linked it to what the CDC and our local and our state health departments were telling us. Now, as everyone knows, you know, what we've learned about COVID has really changed over time from when it started in March, and it didn't even have a name yet. It was just a coronavirus. And then, okay, how does it spread? Is it respiratory? Is it droplet? You know, all of that was evolving. And so what we did, as other organizations did, we kept following the guidance and checking. What we also have to do at behavioral health is sometimes guidance is more medically based. And so that's what we've needed to do. And we do it to this day of taking that guidance and seeing how do we make that applicable to our settings. And so that's an ongoing practice that we have. And just like Frank talked about of just the impact that this has had on our healthcare workers, you know, supporting our staff and leadership is so critically important. They work in such a different way. I started off my career in medical. I was a ICU nurse. So wearing a mask and gloves, you know, that wasn't unusual, but in behavioral health, it is. We do things through groups and interactions where the verbal and nonverbal interaction is very important. That's interactions is like our medication or our procedures. So having to have PPE and mask, you know, to keep everyone safe, but still retain that therapeutic content, that was really important to us. So we engaged experts to help us do that. That was one of the first things that I did in my role is we're gonna need help with this. So we engaged experts and certified infection control professionals that could help us from the day-to-day. What do our units need to look like? And then also regulatory and accreditation experts that would help us navigate that other part of it. Next slide, please. So at our company, we use high reliability principles, and we call those principles in action. And one of the principles that we focused on was situational awareness. What exactly do we have? And that still is so critically important to us. So to start off with, we looked at screening. How are we going to know who might be infectious? Now we've got even greater understanding of what asymptomatic spread is about. But at the beginning, all we had was screening and looking at where staff or patients may have traveled. Have they been exposed? Did they have any physical symptoms? So for screening for our patients, we do that prior to admission. We're located in across the country. We have facilities that are located in Washington State all the way to Puerto Rico. So we have patients we receive at our residential settings that come to us from other states. So that screening process, it's important to start that prior to them arriving to our facilities. So we screen at admission, we screen prior to admission, and then throughout our stay with our patients. And we do that every day, every shift, especially in some of our units where we have geriatric patients. That's been very important. We screen our staff prior to the start of their shift. So that's with symptoms and temperature checking. And then with visitors and others, that's always done prior to the entry into our facility. Testing, that was something early on. One of the biggest hurdles with laboratory testings. It was taking on average 5 to 7 days to get test results. So that really impacted us early on. Very pleased that we have been able to also have rapid testing now. So we have just portable devices, analyzers, that has really helped us. We can get test results now in 15 minutes. And that has definitely helped us being able to test patients before they arrive, or if they become symptomatic in our settings, we are able to test them. Some other special considerations with that, it's like with every kind of protocol that we start, we've got to be able to maintain it. So for any of our settings, we have acute care facilities down to residential treatment centers. We have clinics, we have medication-assisted treatment. So whatever we start, it's really important for us to be able to continue with it and to have a good method, something that makes sense. Even with all of the information that we have, that's still evolving and unfolding. And so some of the special considerations that we've had is just working very closely with our state and local health departments and following their guidance too when it comes to testing. So we're really fortunate right now with rapid testing that one of the reasons why we chose the analyzer that we went with is because the manufacturer had set up a really thoughtful manufacturing process so that we felt good that we would be able to continue to be able to purchase test kits to continue that testing, since so much of our protocols would really depend upon it. Next slide, please. And so PPE and supplies, I remember the early days in March. I mean, we all had PPE, we all had masks, not into the extent or the supplies that we grew to need. And for us, that was one of the first things right out of the gate. Seems like every month there's a new facet that unfolds and a new challenge to conquer. But PPE in March and April with the national shortages was definitely a challenge for us. It's gotten better in the past few months. We were really fortunate that once we were able to order and get supplies in, we converted a construction warehouse that we have into a PPE safe warehouse. So it's nice that we've been able to stockpile that. But in the early days, it wasn't like that. And so what we did is we had facilities, if they already had an ordering relationship with a supplier, we grouped them with facilities that didn't have that relationship because they didn't need the same amount of PPE. And so we grouped them up, partnered them together. So when one facility was in need of PPE, they could contact their facility that they were partnered with, so that they could be able to get supplies. I remember one of our first cases of a positive patient. It was in Washington State. And our plan worked so beautifully on a Saturday where they were running short on gloves, couldn't get any gloves locally, couldn't order them. And they contacted their partner Acadia facility in Arizona, and they were overnighted gloves. That was really a thrill for us to see this, this new process of ours to be put into place and for it to work. I put also here about masks. You know, masks have been a really interesting thing to navigate and encounter with behavioral health patients. As I mentioned, as many of you know, in our environments, being able to see facial expressions and the nonverbal interaction is very important for us with our nurses and our behavioral health associates and our social workers and psychiatrists. Also, masks, interestingly enough, can pose a safety risk because of a connection with ligature risk. So, you know, in some settings like medical settings, masks are, you know, it's a typical item. It's not unusual. For us, it's a different story and something that we really had to navigate. And we had to work really hard through educating our staff and our patients and their families to be able to convert where the possible danger of mask then became something that was seen as safe and something that all of our staff and our patients would be able to wear. You know, mask and distance, just like we hear about that in the community, how important that is, it's critical in our settings as well. So it's definitely been something that we have focused on. Next slide, please. So special considerations, again, as I started off with, would have never thought we would have isolation units the way that we do. But we do, and they're working, and we provide the same type of care, groups and programming, just like if it was not a isolation unit. Again, we really relied on all of the CDC guidance to help us and our experts that we had engaged on how could we create those isolation units, being careful around items such as strings, you know, other things that could be connected to a ligature risk. We also have quarantine and precautionary units if we have patients that we don't know what their status is, or maybe they have symptoms and we did a laboratory test and we're waiting to see if they're positive. We have what we call precautionary units, so we could admit patients. It's very important for us in our communities that we work closely with our medical community centers, because we know just what they're dealing with of taking care of really sick COVID positive patients. We want to be a good partner in our community and help emergency rooms be able to transfer patients, psychiatric patients to us. And so we needed to become that so that we could do it. And we've created those types of units as a result. On those units that have isolation units, we also have donning and doffing stations. So our staff remove PPE that they need to wear if they're taking care of someone who's positive, so that the PPE is removed safely and put on appropriately before they enter into the units. Also, another special consideration is identifying patients that might need to be transferred. These are patients that might have a history, a respiratory history like COPD. And so it's important for us to be able to transfer patients that might be having a compromise so that they can stay safe. Next slide, please. And so what we did, we wanted to create something that would really be helpful to our staff so that there's that consistency around great practice. And this was something we created that we call our universal precautions, and having these be our consistent practices, our tried and true practices around maintaining distancing, wearing a mask, using the 3 C's from the World Health Organization about crowds, avoiding confined spaces, other conditions, washing our hands, covering our sneeze and cough, not touching our face, wearing PPE as indicated, and then cleaning and disinfecting. And we just constantly are reminding every time, let's do this on and off duty, because we know that the spread is actually more in communities than it tends to be in our environments. Next slide, please. Okay, and with that, I have the pleasure of introducing our colleague, Joe Pritchard, the CEO of Pinnacle Treatment Center. Joe?
Thank you, Ann, and thank you, Frank and Kirsten. It's always a pleasure to, an honor to be on a panel with both of you and Kirsten and the National Quality Forum and NABH. I want to start by first really talking about the efforts that not only NABH, but partner associations and provider networks have done early on when this pandemic started and continuing throughout the months and months that we've been having to deal with this. It's been a concerted effort with everyone focused on how do we provide care in the safest possible environment, providing safe services to our patients and providing those safe environments wherever we can for our staff. So it's been a real group effort. And as Frank and Ann mentioned, we've all had to learn on our feet how to adjust and adapt every day to all the new things that we're faced with. I also want to say that in dealing with substance use disorder, opioid use disorder, that we're continuing to deal with an epidemic while living within a pandemic. And so the challenges that we face every day in dealing with the patients that we treat are compounded with all the different environmental changes that have occurred that, as Ann mentioned, really play a part in how we provide care. We're a very interactive, social, very clinically focused care model. And so our patients are engaged, but also our staff. And 90% of our staff are now remote. And so you not only do you have to adjust and adapt to that between the relationship with the clinician and the patient, but between clinicians, the interactions that they're used to having in an environment have changed a lot. But as we started to face this pandemic, we started to, as a NABH, as a committee, the Medication Assisted Treatment Committee and NABH as a whole, begin to look at what we needed to address from a high level that would help us continue to provide care during this pandemic. So we had meetings at the federal level with ONDCP, SAMHSA, DEA, HHS, and CMS to begin to look at regulatory relief and support to allow us to continue to provide the care. And when you're dealing with medication-assisted treatment, some of our environments are highly regulated by the DEA and very restrictive in the states that we operate in. So adjustments had to be made so we could continue to provide care, but not do it in a way that it continuously brings patients into an area that could propose even more risk to themselves and others. So we worked on things like extended take homes. There's a lot of regulations around giving medication, especially methadone. And so the government has allowed us to extend take homes quicker. So individuals did not have to come in every single day for treatment. We were also able to move to curbside and home delivery services. So folks would not have to come into the building because of social distancing. And then at-home delivery for individuals that were either diagnosed with COVID or were living with someone that had to be quarantined. How could we provide those services at home? Telehealth, and I'll get into that a little bit more, but creating a digital platform, not just with providing the direct care, but also providing the support, navigating people into treatment throughout a continuum, and then supporting them around. Shared resources among providers. We wanted to make sure that if during this outbreak, if facilities had to shut down for a day or longer, that other providers, even competitor providers in the network geographic area, could step in and provide treatment so that there was no breakage in that treatment continuum for that patient trying to receive care. Supply chain, and went into a lot of that. We too have an East Coast and West Coast warehouse. We have enough supplies for each of our facilities for at least 6 months. We have a daily burned report that each facility reports in what they're using. With these spikes, we're highly sensitive to the fact that we had peaks and troughs, and we have to be prepared for some locations going through more PPE than other locations. And then special funding. We've worked with the federal government to look at some financial relief because of the time and energy and resources that all of us had to expend. When we get into the use of telehealth, we have to understand that we deal with an at-risk population with patients, but we also have a lot of our staff that are at risk. We have a lot of our prescribers, for example, are semi-retired and older. We have counselors and other medical practitioners that are have other medical complications themselves, or diabetic, and a variety of other things. And a lot of our employees are also recovering from substance use disorder, which puts them in a high-risk population too. So we had to begin to look at how we can move because of the close environments that we're in to a more remote. And we've gone, we treat 32,000 patients every day in 135 locations in 8 states. And within 30 days of going through this pandemic, we moved to 85 or 90% of our treatment is being done remote. And that was a heavy lift. So we had to bring in external resources. We had to spend money for equipment and make sure that not only are we providing good care, but that we're doing it in a protective way. We're still under the auspices of HIPAA and 42 CFR. So we had to ensure that the work that we were doing was being, we were ensuring that we were being protected with our data that we were documenting on our patient care. We have a lot of rules around how we start to engage people in care with medication. And depending on the medication, if you're on buprenorphine, Suboxone, Vivitrol, you can start the induction via telehealth, but we still cannot do that with methadone. And so we still have challenges with the population that we treat with that medication, that initially they have to come in, start induction, and be there for a period of time every day during that to ensure stability and safety. So we've had to take extra precautions in ensuring that we were able to do that. That is why in our ambulatory care settings, there's still 10 to 15% of our staff in the buildings, because we have to take care of patients that are still showing up every day. The rest of our staff are in our residential facilities. The increased cost to providers is not just in PPE. Many of us had to use agency staff to come in to fill in for staff that were not able to come in because they were quarantining or having COVID themselves, or being in a household with someone with COVID, or displaying symptoms that require them to stay away until we could clear them to come back in. We also have overtime, and we have staff helping in other locations and transporting medication to and from other locations, or the curbside and the home delivery. All those have caused increase in cost. We also have a loss in revenue, because a lot of services that we would provide, we could not provide because of the environments that we're working in now. So, there was a lot of challenges up front, and the funding that has come through with the federal government and through the states have helped with some of that, but does not nearly touch all the things that each of us as a provider network have had to put into place. The other things around telehealth and the digital platform is that the government has really stepped up to work with us during this pandemic with what they will allow for clinical engagement. We can use telephonic services, CMS and the payer groups that we work with, the MCOs, are continuing to pay for services, even though they're being delivered in ways that we did not deliver them before. And we're able to continue to provide that care continuously. And we manage that very closely. And I can say that over 92% of our individuals that are receiving remote counseling are staying in care. In fact, a lot of them are engaging more because it's easier for them to engage telephonically when they're feeling despair and some other risk activities that are going on. We are continuing to find that during this pandemic, there's also challenges with provider and patient fatigue. Frank mentioned, and Ann has also, and we do the same thing with regards to trying to engage our staff. We have self-care Zoom meetings on a weekly basis. I do a CEO town hall meeting every week to keep our staff informed of what's going on. Our chief medical officers on the East and West Coast provide bi-monthly calls with all the staffs to continue to walk them through what we're seeing and what we need to do to ensure the highest degree of safety in our environments that we can provide. So all of those things are working, but as this gets more profound and longer, we have to pay attention to all the different challenges that we are faced with, not only with our patients, but also with our staff. We too have created environments in our residential settings that are different. You know, being in on a campus where you have to practice social distancing and wear PPE is a very difficult thing to manage. We've also had spikes in some of our locations with individuals that are testing positive, both patients and staff, with COVID. So we've created COVID isolation buildings and units where we can continue to treat the populations on our campus and manage those who are either infected or have come in contact with those that are infected. Every Department of Health that we have worked with in every state, every community, whenever we've had to talk to them about situations that we're facing, their number one priority, besides making sure people are safe, is to continue to treat the patients that we are for their substance use disorder, because they know that well beyond this pandemic, this epidemic will continue. It's been mentioned by Kirsten that over 40 states are seeing a spike in overdoses. We're seeing a spike in relapses, and folks who are receiving treatment, sometimes in office-based practices, are not able to get there because they're closed. We've had nearly a 3% increase in our census since March, directly related to those things that I just mentioned. So those are the environmental things that we are challenged with every day. The other things around infection control in a residential setting, we need to realize that in most of our settings outside of a hospital, they're very mobile. Our patients are up, dressed, and walking around the campus. They're standing outside smoking a cigarette, sharing cigarettes with each other. And we have to constantly talk to them and manage them for social distancing and making good practice. We have individuals that are, we're doing remote counseling on campus, where we'll have individuals sitting in their rooms or in smaller settings where we can still provide the didactic and group therapy in those settings. We have ambulatory care with partial hospitalization and intensive outpatient programs that we continue to do, but we have to provide those services in a remote setting also. So we're constantly monitoring for ways that we can manage this population and milieu in the safest possible way. One thing I want to tie into with that is around testing. As Ann mentioned, testing is a challenge all across this country in the populations that we're treating within our environments. There's a lot of false positive testing that's going on. And so we're continuously being challenged with having to treat primarily the symptoms that we see and not necessarily rely on all the tests that we get, because we know that they could give us a false positive reading. And so we treat the symptoms as if they were positive. The use of technology within our environments go beyond living within our environments. Frank touched on it a little bit with jails and other agencies. One of the things that we have developed throughout our treatment continuum are patient navigators and peer support specialists. They are fully supported and equipped with digital technology to help, first of all, get patients from the time they make the first phone call into the right treatment environment quickly. Also, how do we wrap peer support around that individual? So as they are trying to live differently today, but being challenged with supports being readily available, how do we drive peer support through digital technology to help support them? These are critical aspects that we need to realize are being challenged. A lot of the support networks that our individuals go through, they go through 12-step meeting support and other support environments, have shifted to digital. And we're just starting to see now some of those meetings starting to open up to be in person, and they're getting ready to be drawn back again because of the spike that we're seeing with COVID. So we have to be aware that the tools that we are used to using outside of treatment to provide support to this patient population has changed. And we have to be ever mindful of the things that we have to do to help drive that initiative. That is all that I have. I'd like to turn this back over to Kirsten.
Thanks, Joe. As we're getting close to the end of our hour, just wanted on the next slide, there are some of our advocacy priorities. Obviously, telehealth is critical. If you could go to the next slide, Amanda. Continuing the expanded coverage, including of audio only, and also the flexibilities around medication-assisted treatment, very important to continue those, as well as flexibility around practitioners, clinicians being able to operate to the full extent of their license. These are things I've heard consistently from our members as being really helpful during this time, and really important to continue. The funding has, as Joe mentioned, federal funding has been helpful. There have been some challenges around the reporting requirements. I'll leave it at that. That needs to be simplified. Next slide. We have advocated consistently that waiver of the IMD exclusion may be a way to free up inpatient beds, but that has not been taken up, even though there is existing authority to do that, as well as addressing some of these other needs. Important to think about and prepare for 988, a universal crisis hotline that needs to be implemented in every state, needs a lot of resources. Parity continues to be a challenge, and then we, as Joe mentioned, we need to allow for induction into methadone treatment via telehealth. So we have a couple minutes for questions, I guess, Amanda, if you want to open it up. And go to the next slide.
Yes, if you, our lines are opening for questions. You can also use the chat box at the bottom of your screen. If you are joining us on the phone, please use *6 to unmute your line. And then after you've asked your question, you can use *6 to mute your line again. So if anyone has any questions, please feel free to share them. So Tim Jones, yes, the slides will be shared at the end of this presentation as well as a recording. Eric Sharp says, thank you for the interest in peer support. Can you talk more about how to expand the use of peer support specialists in this work?
Sure. So peer support has been ever evolving over the last 10 years. I think what we're starting to see now is that more states and more payers are recognizing it as a critical tool in how we manage the treatment of individuals suffering from substance use disorder. One of the things that we have done is worked with the states that we're in with developing pathways for individuals to become certified as peer support specialists. We've also partnered with other organizations that focus specifically on providing peer support, and we've aligned ourselves with those groups so they would be providing that aspect of care in our continuum. And we're looking at developing our digital platform, one that we use that allows us to stay connected from patient navigation all the way through to peer support, and our alumni support groups using the same digital platform. So there's a continuous engagement with that individual throughout the continuum.
Right, thank you. Our next question is, do you have information on the effectiveness of telehealth as an alternative to traditional services?
I can field that one. We did an internal survey back, I think it was in August or September, reached out to several thousand individuals who were receiving telehealth and asked them a series of questions about the ease of it, whether or not they felt that they were had an alliance with the person doing treatment, and about the effectiveness as it related to their intended goals and outcomes. And it was overwhelmingly positive. In some cases, when we asked them to compare it to previous treatment, some people even said it was superior, primarily because they had found the transportation of getting back and forth pre-COVID to be a barrier for them, and this had removed it. So that said, it's been very positive. There are a couple of populations I worry about. I worry about people with autism disorders. They have a difficult time with this. People who are acutely psychotic, and sometimes cognitively impaired elderly. So it's not a panacea for all.
Great, thank you. Are there any other questions on the line? Again, if you're on the telephone, you can hit *6 to unmute, and you can use the question and answer box at the bottom of your screen if you're joining us via the web. All right, well, thank you to each of our panelists. And in closing, I would like to thank the National Association of Behavioral Healthcare for assembling this wonderful panel for us, and for you all taking the time to share with our NQF members your experiences in dealing with COVID. I would also like to thank all of you, our attendees, for joining us today. We hope the information that was shared today will be informative as you face these challenges in your organizations. We know that many of you are on the front lines of the response, and we are grateful for your leadership and action. Please look out for a brief survey following today's program. If you could take 60 seconds to give us your feedback, we would appreciate it. We will upload this member webinar to our Member Connect portal, and also the recording to our NQF YouTube channel. And with that being said, this concludes our program. On behalf of everyone here at NQF, we wish you continued good health. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you.